Diese
data as
Konferenz
well,
wird nun aufgezeichnet.
and some background as well to soft tissue sarcomas.
That is great. So would you like to start, Robin?
Yes, well, thank you very much, Catherine and Michaela, for the invitation. It's a real pleasure to give this webinar, and I'm very, very grateful to you for all your help in setting this up. So the title of this presentation is Olaratumab in soft tissue sarcomas. These are my disclosures as a consultant, and I'd like to start off by just giving a very brief overview of sarcomas. Of course, they account for about 1% of adult cancers and are made up of many, many different subtypes, and also can affect any part of the body. So those three things, the rarity, the heterogeneity, and the wide distribution in terms of anatomical primary sites, makes these tumours very difficult to diagnose and treat, but also very difficult to perform clinical trials, primarily because of the rarity and heterogeneity. In terms of drug development, I think it's really useful to think of these tumours in terms of biological groups, the most common being those with lots of genetic alterations, so tumours with a complex genetic makeup. There are other types of sarcomas as well. There are many that have specific chromosomal translocations that generate fusion oncogenes, and examples of these include synovial sarcoma, myxoid liposarcoma, and Ewing sarcoma. In addition, within this group of simple tumours, or more simple tumours, are those with specific kinase mutations, and gastrointestinal stromal tumour, or GIST, is a notable example in this group. In addition, there are tumours characterised by gene inactivation, so NF1 in malignant peripheral nerve sheath tumour, or MPNST, INI1 loss in rhabdoid tumours and epithelioid sarcoma, as well as APC in desmoid tumours. And lastly, there are tumours characterised by just simple genetic alterations, and these include amplifications of MDM2 and CDK4 in well and dedifferentiated liposarcoma. And in the past, particularly for soft tissue sarcomas, all of these different types of tumours have been lumped together for the purposes of clinical trials and research. But there is a lot of evidence to suggest that it's better to think of these different sarcoma subtypes as different diseases. And the introduction of multi-agent chemotherapy for certain types of sarcoma in the localized disease setting, including osteosarcoma, Ewing sarcoma, and rhabdomyosarcoma, have really been among the great success stories of oncology. And it's important to note that different drugs or different combinations of drugs are active in these different diseases. And in the metastatic setting, when the cancer has spread elsewhere, there are a number of published studies and research articles highlighting the efficacy of specific drugs in specific diseases. Gastrointestinal stromal tumour was a notable example, with the introduction of an oral drug, a tyrosine kinase inhibitor called imatinib, that targeted KIT and PDGFR-alpha. But there are other examples, including imatinib in dermatofibrosarcoma protuberans, denosumab in giant cell tumour of bone, anti-angiogenic agents such as cediranib, sunitinib, and pazopanib in alveolar soft part sarcoma, ALK inhibitors in ALK-mutated inflammatory myofibroblastic tumour, mTOR inhibitors in pecomas, aromatase inhibitors in endometrial stromal sarcoma, and the list goes on. But each one of these diseases is very, very rare, so it just gives you an illustration of how difficult it is to perform clinical trials in a particular histological subtype. I mentioned the use of imatinib in GIST, and there was a rapid development of this agent from early stage phase 1 clinical trials to large randomized phase 3 trials leading to registration of the drug. And this has really been the paradigm for so-called targeted therapy in solid tumor oncology. And of course, imatinib is a relatively well-tolerated agent and very, very effective in gastrointestinal stromal tumor. Other registration trials have led to the approval of drugs called sunitinib and regorafenib in this disease, and there are a number of promising agents currently under investigation in phase 3 trials. So the topic of this evening is Olaratumab, and the phase 2 trial of Olaratumab in soft tissue sarcomas was very, very successful, and as Catherine mentioned, led to the approval of the agent in soft tissue sarcomas. But there was also a phase 2 trial in gastrointestinal stromal tumor, and this was a smaller trial with 30 patients. There were 2 cohorts, those with PDGFR alpha mutations, and of course Olaratumab targets PDGFR alpha. And there were 6 patients recruited, and 3 of these patients had stable disease on serial imaging, and the median progression-free survival, the time from starting the drug to the cancer progressing, was 32 weeks. And in those with PDGFR alpha mutations, 14 were recruited, 2 had stable disease, or 14%, and the median PFS was 6.1 weeks. So in terms of the treatment of metastatic soft tissue sarcoma, there are a number of options available. For people with relatively low volume indolent disease, and if they're asymptomatic, observation is a good option. For patients with symptomatic disease or large volume burden disease, chemotherapy is the mainstay of management, but other techniques can also be used to treat metastatic soft tissue sarcoma, including radiation, palliative surgery, ablation procedures such as radiofrequency ablation and cryotherapy, as well as embolization procedures. And for patients with many comorbidities and who are not well because of their comorbidities and their disease burden, best supportive care can be the most appropriate option, rather than exposing people to the possibility of severe side effects from chemotherapy type treatments. And in the story of Olaratumab, it's really important to give the context of first-line therapy for metastatic disease. So over the last few years, 4 randomized trials have been published analyzing the optimal treatment schedule for first-line therapy in metastatic soft tissue sarcomas, and these are listed on this slide. The first was performed by the European Sarcoma Group within the EORTC, and this trial allocated people to either receive doxorubicin or the combination of doxorubicin and ifosfamide. And this trial showed no difference in overall survival between the 2 arms of the trial, but the combination of doxorubicin and ifosfamide resulted in significantly longer progression-free survival and a significantly higher response rate. The next trial listed here, the so-called Picasso trial, randomized people to receive either doxorubicin plus placebo or doxorubicin plus palifosfamide, an ifosfamide analog with fewer side effects. But this trial showed no significant difference in overall survival or progression-free survival between the 2 arms. And similarly, the SARC-21 trial randomized people to receive either single-agent doxorubicin or doxorubicin plus ivosfamide, And ifosfamide is a hypoxia-activated alkylating agent. So it is similar to ifosfamide, but activated in hypoxic tumor tissue. And this trial, again, showed no significant difference between the two arms in terms of both progression-free survival and overall survival. And finally, the British GEDIS trial allocated people to receive either doxorubicin or gemcitabine and docetaxel. And similarly, this trial showed no significant difference in terms of progression-free survival or overall survival between the two arms. So this slide just reinforces the role of doxorubicin as first-line therapy for metastatic soft tissue sarcomas. And just to go over the EORTC trial, as I mentioned, there was no significant difference in overall survival. So median overall survival, 12.8 months for doxorubicin versus 14.3 months for the combination. And similarly, for survival at 1 year for doxorubicin, 51%, and for doxorubicin and ifosfamide, 60%. But for in terms of progression-free survival, the combination had a significantly longer progression-free survival of 7.4 months compared to 4.6 months for single-agent doxorubicin. And in addition, the combination had a significantly higher response rate, so nearly 27% versus 14% for doxorubicin. So the combination of doxorubicin and ifosfamide may and still does have a role for patients who are very symptomatic due to their metastatic sarcoma, for patients with rapidly progressive disease, or in patients where we really need to get a response rate to enable other forms of treatment such as surgery or radiation. And again, in the context of the approval of Olaratumab based on the randomized phase 2 trial, it's important to highlight that there are other increasing number of options available to treat metastatic soft tissue sarcoma. We can always fall back on ifosfamide. Ifosfamide is an active drug, but of course has many potential side effects, including hemorrhagic cystitis, so blood in the urine, potential kidney failure, as well as an encephalopathy, so drowsiness, and in extreme cases, it can result in a coma. There are other combinations that can be used, so gemcitabine and docetaxel, gemcitabine and dacarbazine. Pazopanib has been approved based on a randomized placebo-controlled phase 3 trial. Trabectedin has been approved based on a randomized phase 3 trial in lipo and leiomyosarcoma, randomizing patients to receive either trabectedin or dacarbazine. And similarly, eribulin has been approved in liposarcomas, again based on a randomized phase 3 trial versus dacarbazine. And dacarbazine as a single agent can also sometimes be used. So moving on to Olaratumab, as I mentioned, this is an anti-PDGFR alpha human monoclonal antibody. It selectively binds to PDGFR alpha with high affinity. And you can see on the cartoon on the right-hand side the representation of Olaratumab binding to PDGFR alpha. And by doing this, it blocks PDGF binding and PDGF-induced activation of PDGFR alpha. And Olaratumab demonstrated activity in both in vitro and in vivo cancer models, and demonstrated activity in these models when they were driven by PDGF binding to PDGFR alpha in an autocrine loop. And in other experimental models, Olaratumab demonstrated anti-tumor activity as a single agent or in combination with doxorubicin in human sarcoma models. So the trial that I was involved with was the phase 1b, phase 2 trial in soft tissue sarcomas. But prior to that, there was a phase 1 trial with a dose escalation component. So patients were treated at a certain dose, and if that was tolerated well, then the dose was increased, and that was open to people with all types of solid cancer. But the phase 1b, phase 2 trial, the phase 2 component included a randomized, it was a randomized trial. It was open label, so we knew which arm of the trial people were randomized to, and it was open to patients with advanced soft tissue sarcomas. And the trial, as Catherine mentioned, resulted in the approval of Olaratumab based on the overall survival benefit shown for the combination of Olaratumab with doxorubicin. So this is the design of the phase 2 component of the trial. So as I mentioned, patients with advanced soft tissue sarcomas were eligible. Patients had to be over the age of 18, had to have a performance status of 2 or less, and could have received any number of prior treatments, but they could not enter if they had received prior anthracycline drugs, so prior doxorubicin type drugs. And they had to have previous tumor material available to determine the PDGFR alpha status on immunohistochemistry. And the people randomized into the trial were stratified or grouped according to the PDGFR alpha status, the number of lines of prior treatment received, ECOG performance status, as well as the histological subtype. And you can see from the diagram that patients were either allocated to receive doxorubicin 75 milligram per meter squared on day 1 for 8 cycles, or were randomized to receive Olaratumab 15 milligram per kilogram day 1 and 8, plus doxorubicin on day 1 for 8 cycles. And those allocated to the combination arm could carry on with single agent Olaratumab until disease progression. Those randomized to receive single agent doxorubicin had the option of Olaratumab monotherapy following progression. So the primary endpoint of the trial was progression-free survival. Secondary endpoints included overall survival, objective response rate, progression-free survival at 3 months, change in tumor size. There were various exploratory pharmacokinetic endpoints and also exploratory endpoints analyzing PDGFR alpha status and clinical outcome. And because in this trial, patients received 8 cycles of doxorubicin, which is more than the standard 6 cycles, which are usually given, the risk of heart damage increases dramatically after 6 cycles of doxorubicin at a dose of 75 milligram per meter squared. The investigators within the trial could use the cardioprotective drug dexrazoxane from cycle 5 onwards, and that was at the discretion of the treating investigator. This slide gives the breakdown of the histological subtypes in both arms of the trial. So relatively well balanced for some of the more common subtypes. So leiomyosarcoma was the most common subtype overall. 36% in the combination arm, 40% in the single agent doxorubicin arm, and then going down, undifferentiated pleomorphic sarcoma, 15% in the combination, 21% in single agent doxorubicin arm, and similarly for liposarcoma, 12% in the combination, 22% approximately in the single agent doxorubicin arm. But you can see that there are a fair number of people with other soft tissue sarcoma subtypes, just illustrating the heterogeneity of these diseases. So 25.8% in the combination arm of doxorubicin plus Olaratumab. So as I mentioned, the primary endpoint of the trial was progression-free survival. and the trial technically met its primary endpoint. So the median progression-free survival was 6.6 months for the combination and 4.1 months for single-agent doxorubicin, with a hazard ratio of 0.67. But the thing that really made this trial notable was the difference in median overall survival, which is shown on this Kaplan-Meier curve. So the a combination of doxorubicin and olaratumab highlighted in the red curve, and then the single agent doxorubicin highlighted as the dotted curve. And you can see that the median overall survival in the combination of doxorubicin and olaratumab arm was 26.5 months versus 14.7 months in the single agent doxorubicin arm, with a hazard ratio of 0.46. And this was a very statistically significant result. And looking at the stratification factors, the grouping factors that I mentioned earlier on, this benefit extended to most of these different groups, including performance status, histological subtype notably, which we divided into leiomyosarcoma and the heterogeneous group of other sarcomas, as well as the number of lines of previous treatment as well. In terms of response rate or tumor shrinkage on the trial, the objective response rate in the combination of olaratumab and doxorubicin arm was just over 18%, compared to about 12% in the single agent doxorubicin arm. Although this was numerically higher, it didn't meet statistical significance. So a summary of the phase 2 trial shows that the combination of doxorubicin and olaratumab met its predefined statistical primary endpoint for progression-free survival. But notably, the combination achieved a highly statistically significant improvement of nearly 12 months in median overall survival compared to doxorubicin alone. And this improvement in median overall survival was achieved without an increase in serious toxicity, despite the higher than usual cumulative exposure to doxorubicin. So as I mentioned, patients in the phase 2 trial received 8 cycles of doxorubicin as opposed to the standard of 6 cycles. And this busy slide just illustrates the duration of treatment, the number of infusions, and the cumulative doses achieved in both arms of the trial. But I think that the really important thing here is the relative dose intensity between the 2 arms. So essentially 99% in both arms. And then the bottom part of the slide just shows the duration of treatment with olaratumab and the number of infusions of olaratumab received in the combination arm. And then this slide just lists all of the adverse events in both arms. So as I mentioned, the combination was really well tolerated. The serious events, the grade 3 and the grade 4 events, are listed in the columns here. But again, no major concern in terms of any untoward safety signal from the combination of olaratumab and doxorubicin. So this, as I mentioned, has led to the initial approval of olaratumab. But as Catherine mentioned, there has been a phase 3 trial allocating people to either receive doxorubicin plus olaratumab or doxorubicin plus placebo. And this was a multi-center international trial with overall survival as the primary endpoint of the trial. And that trial has closed to recruitment, and the results are expected later next year. So I think everybody's very, very excited to hear the results of that large randomized phase 3 trial. But in addition, there are a number of other very interesting trials of Olaratumab. In various sites in Europe and the United States, there's a phase 1, phase 2 trial of doxorubicin ifosfamide plus Olaratumab. So again, this is a very important trial to document the safety of Olaratumab with the combination of doxorubicin and ifosfamide. And as I mentioned earlier in the presentation, for some patients with metastatic sarcomas, the combination treatment is very important, particularly if they're very symptomatic or have rapidly progressive disease. It's important to consider the combination in order to get a rapid response and rapid relief of symptoms. The other thing to note about this trial of doxorubicin and ifosfamide in combination with Olaratumab is that it may be important to use this combination if there is an adjuvant trial of Olaratumab. So if there's a pre or post-operative trial, because in the pre or post-operative setting, we often use the combination, as I mentioned, because of the higher response rate. There are also interesting trials. There's one trial, a phase 1, phase 2 trial of gemcitabine docetaxel plus Olaratumab. And the phase 1 combination, the phase 1 trial documented the safety of this 3-drug combination, and then the phase 2 component allocated or randomized people to either receive gemcitabine docetaxel plus placebo or gemcitabine docetaxel plus Olaratumab. So again, a very interesting trial of Olaratumab in combination with a well-used schedule in sarcomas. There's also been a phase 1b trial of preoperative Olaratumab in combination with doxorubicin, and this it was basically to look at various biomarkers of response to Olaratumab and to try and tease out the precise mechanism of action of the drug. So we're looking at the pre-treatment biopsy specimen, but also at the post-operative specimen to see what changes during treatment to try and identify people most likely to benefit from treatment with Olaratumab. And the other very interesting trial is of the PD-1 inhibitor pembrolizumab in combination with Olaratumab. So there are 5 very interesting and varied trials there of Olaratumab in combination with other agents. So as mentioned, the FDA and EMA granted conditional approval for Olaratumab pending the phase 3 trial results. We've been, and other institutions have been, auditing the ongoing use of doxorubicin and Olaratumab off trial in real life settings, particularly in patients who've got various comorbidities, documenting the toxicities. And we've got an ongoing audit at the Royal Marsden right now that we've not presented yet, but again, it gives us an insight into the real world use of this drug. And as I mentioned, the results of the phase 3 trial are due to be available at the end of 2019. So I think in conclusion, there are increasing number of systemic therapy options available to treat metastatic soft tissue sarcomas. The results of the phase 2 trial of doxorubicin and Olaratumab are very promising, particularly the impressive improvement in overall survival. And there are a number of very important ongoing combination trials of Olaratumab with other schedules that are used in sarcomas. And we and other institutions are auditing the real life experience with Olaratumab and doxorubicin in the actual everyday clinical off-trial setting. And as I mentioned, the results of the phase 3 trial are eagerly awaited. And with that, I'd like to say thank you and would welcome any questions.
So thank you very much, Robin, for this presentation and for giving us a lot of background, a lot of things to think about. But yes, I would like to welcome everybody who has a question to ask right away, please. Anyone? Okay. Maybe, Robin, I actually do have a question myself. You just mentioned that you are auditing Olaratumab in real life, in a real life setting. Is there? Do you plan to publish anything on that? Is there anything planned that you will share?
Yes. So we will be publishing that as soon as we've got all the data analysed. So that's in progress now, and we're hoping to to present that at some point next year, probably before the results of the phase 3 trial are available. But wow. That's a work in progress. But because we've not presented or published it, I can't divulge the information today.
I wasn't planning on making you do that. So that's going to be interesting. I'm looking forward to that. And,
yeah, no, it will be interesting.
Maybe another question, if I'm not interrupted by anyone else of our listeners. No questions? Okay, then you mentioned before, well, the approval is pretty wide open, let me put it that way, for Olaratumab for all the soft tissue sarcomas. But do you have any subtypes you prefer to put on Olaratumab, or how do you decide which patient receives the drug and who doesn't?
So that's a really good question. I think based on the phase 2 data and the fact that leiomyosarcoma was the most common histological subtype, I think clearly leiomyosarcoma is a subtype that really benefited from the drug in the phase 2 trial. I think for other subtypes such as synovial sarcoma, so there were only 3 patients with synovial sarcoma in the phase 2 trial, and I think most oncologists would recommend combination treatment with doxorubicin and ifosfamide for patients with metastatic synovial sarcoma, unless there were reasons not to give ifosfamide. So I think we're still learning, and I think the results of the phase 3 trial will be really important in that respect. But I think from provisional data, the results of the phase 2 trials suggest that leiomyosarcoma patients clearly benefit from the drug, but there's very little information regarding use of the drug in subtypes like synovial sarcoma.
Okay, then we hope we'll know a little more next year, by the end of next year, with the new results of the phase 3 trial.
Yes, and the phase 3 trial I think is very important because the phase 2 trial was a small number of patients, so it's important to have the results of the phase 3 trial. Very important because of the heterogeneity of sarcomas. It's really important to have a large trial to to confirm the promising results from the phase 2 trial.
Okay, we'll just wait and see, I guess. But
yes.
Are there any questions from our listeners? Last chance.
No. Otherwise, my English is not so good. I heard from some patients feedback from some patients that they get the Olaratumab and the doxorubicin only for 6 cycles, because in Germany the cardioprotective drugs not allowed, or the health insurance, they won't pay for it. What do you think? Is it a benefit if you only give it for 6 cycles together with the doxorubicin? Because all of this, the trials, they work with 8 cycles.
That's an excellent question. So I think in many countries, so in the United Kingdom as well, we can only use the combination for 6 cycles. I think we don't know the definitive answer to that question. The selection of 8 cycles in the phase 1, phase 2 trial was based on preclinical, but based on laboratory data from Dr. Schwartz's laboratory, and I think it's very difficult to extrapolate. I suppose the regulatory, the funding approval, the majority of people are under the or think that you know the benefits of giving 2 extra cycles of doxorubicin from 6 to 8 wouldn't result in such a profound improvement in overall survival of about 12 months. But I think we don't know the definitive answer to that. For what it's worth, my opinion is I'm happy administering 6 cycles. I don't think that the addition of another 2 cycles of doxorubicin to make it 8 in total would have such a profound effect on improving overall survival by 12 months.
But the phases 3 trial also was with 8 cycles.
Yes, so to replicate the phase 2.
Okay.
But I think there's a lot of variations. So, you know, in the United States and in various other countries where it's easier to prescribe the cardioprotective agent dexrazoxane, it's easier to give 8 cycles. So I think that's where auditing the use of the combination of doxorubicin and olaratumab in, as I say, in the real life setting is very important and will give us additional information. So I think it's really important that people do that outside the context of a clinical trial.
Okay, thank you.
That's a very good question. Thank you.
Do we have any more questions?
Hi, it's Richard from Sarcoma UK. I just have a question about the cost of a course of Ola.
Sorry, I couldn't hear that.
Can you hear me now?
Yes.
Can you just tell me what the cost of a course of Ola is?
So the cost of, I'm not sure what the cost of 6 cycles, because I think it varies between countries. I'm not sure what the precise cost in the UK is. I think they reached a compromise in terms of you know, the cost and getting the drug approved, but I can get that information to you.
Thank you.
Any more questions? Okay, seems like No. Then I'd say we close the webinar, and it leaves me to say thank you very much, Robin, for joining us for today and to hold your presentation. It was very interesting. Thanks a lot, and thank you also to our listeners today. I just want to point out that we have recorded this session and will put it on our website and our YouTube channel, as well as the other webinar we had 2 weeks ago. So just watch our social media channels, and we'll let you know once it's online. So, Robin, again, thank you very much.
Thank you. It was a pleasure.
Great. Thank you.
You.
And goodbye, everyone.
Bye.
Bye.